Thank you so much for having me. Thank you, Bridget, for helping to, and as well as the rest of the organizing committee for getting together such a dynamic group of individuals who are motivated and dedicated to come together to learn about a new topic from a lot of different angles. And so thank you for inviting us here and for the opportunity to share our knowledge with you and to continue learning from you. Because it's really by us presenting that we get the feedback from you guys, and we're able to develop new knowledge and research in this area to meet the needs that you guys see in your clinical practice. And so I have a set of 3 lectures for you guys, and the first one is talking about an overview on pediatric sleep-disordered breathing. First, a little bit of background about myself. My name is Sarush Zaghi. As I explained, I'm an ENT sleep surgeon. I graduated from Harvard Medical School. I did my residency at UCLA in ear, nose, throat surgery. And then I went on to complete a fellowship at Stanford University in sleep apnea surgery. I'm a medical director and co-founder of the Breathe Institute, and it's a collaborative group that we help develop to bring in individuals from different perspectives to help treat sleep and breathing issues in children and adults. I'm a speaker for various organizations, and I also am a volunteer consultant for various groups who are interested in doing research. And really thankful for the opportunity to come out here. I think I was invited almost a year ago when I agreed to come out, and I had no idea that I would use this opportunity to propose to my fiance. And this is us a couple days ago, and that's Mount Warning in the back. It's a shield volcano. It's about 22 million years old, and it's a historic and a very holy site for the indigenous people of this area. And so I really enjoyed seeing that video and exploring a little bit of the culture from the elders and the previous people who shared these lands. And we also got to spend a little bit of time at Byron Bay. And I actually brought our whole team with us here to reward them, dedicate for their contribution as team members. So we have Layli here. She's the managing director. She had wanted to do something like the Breathe Institute, bringing together multiple perspectives for like maybe 5, 6, 7 years. I have Sandra there, who's my myofunctional therapist. And it's really by working together closely over the last 2, 3 years that we've been able to advance the field. Just working side by side, seeing patients together. And there's my new fiance. So before this, as I explained, I'm a Stanford-trained sleep surgeon. And that means that I bring a multidisciplinary perspective to sleep and breathing issues. So I have exposure to sleep medicine, just treating people based on the standard of care, ENT approaches, dental approaches, myofunctional approach, and maxillofacial surgery approaches. And it's really by understanding and studying all these things that we're able to work together to advance the research. And so this kind of shows you the number of research projects I've been involved in the last just 1 or 2 years. And I have a very broad interest, really anything that's novel and interesting, and I can find a partner who's willing to study it. I'm more than happy to collaborate and kind of work together to advance the field. And so what my research has brought me to now is my passion, which is really pediatric sleep and breathing from an ENT and myofunctional approach. And so what this means is that yes, taking out the tonsils and adenoids is sometimes necessary to prescribe medications. But if we can avoid these things through therapeutic approaches, that's what we want. Because we really want our patients to do well, whether it's with surgery or not. And kids are so cute, and it's really a joy to work with them. And so here's a picture of a cute baby. Is the sound up? And look at how cute he is. Isn't it cute how he's snoring? Isn't that cute? No, it's absolutely not cute. It actually should be titled Concerning Snoring Baby, because snoring is never normal, especially in a young baby who's presenting like this. And so what we really want is optimal and healthy nighttime sleep and breathing. And what that means is that breathing should be quiet, shouldn't be audible, it should not be noisy. They should be breathing through their nose exclusively, with almost no mouth breathing. So 90% of the time, they should be breathing through their nose. And the lips should be closed with the tongue suctioned to the hard palate. So we're here to talk about tongue tie. And my lectures throughout the day and throughout the weekend are going to be focused on tongue tie. But the first lecture, I just want to show how the piece fits into the overall picture. Because it can be very easy, if I give a lecture just about tongue and sleep, to assume that all sleep issues should be treated with tongue tie release. And so we're going to take a step back and really point out that yes, absolutely, 100%, the facts show that tongue tie is definitively part of the puzzle. But it's not the only piece in the puzzle. And so this first lecture is going to give us an overview about sleep disorder breathing in general, and quickly touch on the various aspects and point out in which cases and how does tongue tie fit into the overall picture. And so thank you for the extra time that you allotted me to make sure that we address all that. And so I'm honored to provide you guys with 3 lectures. And so the first one is going to give you an overview on pediatric sleep disordered breathing, development of the maxillofacial complex, and the impact of tongue tie. The second lecture this afternoon I'm very excited to share with you guys. It's a review of the literature. Again, we're talking about the facts, and I'm very excited to go through one by one the history of the research by my mentor, Christian Guilleminot, in terms of how he started his career and where he's passing off the baton to the next generation. And I'm really excited to go through with you guys on that. And then finally, tomorrow afternoon, I'll demonstrate to you guys what we're doing in our clinic and how we're approaching it today, and what we're learning as we move towards the future standards of care. And so, in this conference, we're talking about lifelong implications. And so I'd like to introduce to you one of my patients. His name is Austin. And so Austin is now a 27-year-old male. But when he was growing up, he's always had issues with ADHD. He had unrefreshing sleep as a child. Developed loud snoring. Maybe it was cute, until it was too loud and it was noticeable and bothering his siblings. Around 15 or 16 years of age. But no reason to do anything about it, until it got worse and worse and worse. And he had a sleep study that showed he had an apnea-hypopnea index of 13 events per hour, that he had mild to moderately severe sleep apnea. And so it's easy to just say someone has sleep apnea. But let's just take a look and see what this means when they're sleeping throughout the night. So this is called drug-induced sleep endoscopy. We force patients into a state of sleep using medicines. And then we can observe to see how they react if we allow them to go into a deep, deep sleep. A lot of these patients with sleep apnea are stuck in a state of light sleep, which is why they're unrefreshed. And so what would happen if we let Austin go into a deep, deep sleep? So what he's doing here is he's making this noise to keep his airway open. He's compensating. No oxygen loss, no breath holding. But this is not normal, and far from it. And so as we talk about sleep and breathing issues, it's not only about the sleep and breathing, but it's also about the compensations people do to push through. And so as we talk about tongue tie issues, it's not only about the tongue tie, but it's also about the compensation patterns that the children and adults have to go through to cope with the underlying problems. And so here we see that if we move his jaw forward, this is going to open up his airway and alleviate the obstruction. So when we're talking about obstructive sleep apnea, we're talking about the fact that the throat is closing off, preventing you from the most vital function that you need to do, and that's to breathe. He just wants to breathe. And he's choking on his own anatomy. And so we use this little scope to kind of take a look inside and see what's causing him. What's causing it to obstruct? Is it the tongue? And yes, it's the tongue to some extent, but in this case, it's also the maxillofacial structures. And so based on the results of this, we're seeing that he has a really narrow and posterior maxilla. and there's just not enough room for the soft tissue structures in the back of his throat. And as he goes from light sleep to deep sleep, all the muscles in his body relax, and the throat and the tongue are those muscles, and it obstructs, it falls back. We pull the jaw forward, and the resolution resolves. We let it go. He can't breathe. He cannot breathe. And look what happens to his legs. So now we know why he has cramps in his legs. This is sleep apnea. And it's my passion to prevent this, if possible. And so for him, he's a little bit too late for tongue-tie myofunctional therapy as an initial treatment option. And so we had to go to the be-all and end-all of treatment, and this is the maxillary mandibular advancement surgery. And this is a surgery I recommend in maybe 2 or 3% of my patients, but sometimes, like we see in this case, it's absolutely, absolutely necessary. And here he is at Stanford just after my fellowship. I took him here for the surgery with Dr. Stanley Liu, who's one of my mentors in this field. We planned out a maxillofacial orthognathic surgery to bring forward his upper and lower jaws and to open up his airway. And so we went to check up on him just the day after. Thumbs up from the patient. One day out, he writes a note to me. I haven't slept that well in a long time. Last night, I could only sleep 2 hours. I was feeling so sick this past month because I could never sleep. I am so happy, you have no idea. And let's see him 2 months later.
Up, I just feel so tired. My parents got on my case all the time for being late for elementary school. They said, why can't you just wake up? Why can't you just go to school? And it was just, I just always have this fatigue. And then even until before the surgery, I go home and I just feel sad. I feel sad and tired, and it's actually why I started working out every day for an hour, hour and a half at the gym. I lift weights because it gives me energy, it gives me endorphin release to make me feel happier. And then finally, I got the surgery, and those feelings of sadness went away. I just wasn't sad anymore, and I was just happy. I was a lot happier. I feel a lot calmer. My anxiety is gone. My brother actually was talking to me. He says, you don't have anxiety in your voice anymore. And then I had dinner with a friend. She's like, wow, you're so much calmer now. It's like you're like a different person. And now that I realize that, I mean, maybe there were other factors that contributed to my depression. Maybe I did have ADD. I still believe that's a possibility. But I also believe that the sleep apnea aggravated a lot of these things that I wouldn't have had if I had treated this earlier.
Beautiful, beautiful. And so here he is, and he tells me, you've given, dear Dr. Zaghi, thank you for being so personable and understanding to me as a doctor. Your services have been life-changing, and you've given me my life back. I look forward to what my new future holds for me. I wish you the best in your wishes and endeavors. And just 2 days ago, he wished me congratulations on my engagement. And so we're seeing the case of Austin. And Austin is on fire. And the standard of care in our community right now is that we treat patients with sleep apnea when they're on fire, when the tonsils are so big it's blocking up the throat, when the sleep apnea is so severe it's causing them to be anxious and depressed and falling asleep at the job or at the wheel. But wouldn't it be better if we could intervene when there's smoke? And that's the concept of this lecture. So what does effervescent breathing look like in kids? So here's a kid, maybe like Austin, maybe years earlier, who doesn't have sleep apnea. He never stops breathing. He doesn't lose any oxygen. But look at how much effort he has to do in order to breathe. And he's doing an HRPO study, and this study will come back normal because our diagnostic tools are inadequate for adequately identifying these patients early on. And this also makes our outcomes challenging, because if this patient's considered normal to start, what kind of endpoint are you looking for? And so that's why we're working to develop new tools and guidelines to more effectively diagnose these patients. And so our current guideline is exclusive nasal breathing. Quiet, exclusive nasal breathing. Because mouth breathing can lead to noisy breathing, that can lead to snoring, that can lead to sleep apnea. And it's important to say that not all mouth breathing will lead to sleep apnea. But most of the time, sleep apnea starts with some snoring, and some snoring starts with some noisy breathing, and the noisy breathing starts with mouth breathing. So if we can jump in when they're early and do safe interventions, therapeutic interventions, to help them with their mouth breathing in a problem-solving way, maybe we can prevent the progression to sleep apnea. And so what does sleep apnea look like in kids by contrast? And so here we have two kids with obstructive sleep apnea. And what you'll see in the boy here is that his chest is pulling in. His throat is closing up, and his diaphragm is pulling down. He's trying to take a breath, and it's closing in. And he can't breathe. You can see his chest flaring. And so he's not breathing, and he has to turn on his side. And they get aroused. They fall out of the deep sleep. They go to light sleep. And if they don't wake up, they can have consequences. They can have behavior and learning issues. They might be a moody child who's unable to regulate their emotions. They might exhibit bullying behavior at school. Moodiness, inattentiveness, disruptiveness, poor academic performance, or atypical ADD. How about some kids who have bedwetting from the high degree of sympathetic tone? Imagine the fright of not being able to breathe and the effect that has when it's hour after hour, minute after minute, while you're sleeping each and every night. And when you're not getting into that deep sleep, in the stage 3 sleep, that's when growth hormone is released. And so one of the most incredible things is you treat these patients and you just see them grow. And it can also cause insulin resistance, obesity. When you're not sleeping well, the hormone chemicals in your mind changes, and it promotes you to go towards fatty foods and not want to exercise. And as it starts from childhood to adolescence to adulthood, that's when you're seeing these individuals in their 50s and 60s with cardiovascular events because of this. So when we see our pediatric patients, we want to start with some questions. Is there any snoring? Can you hear it when they breathe? Are they gasping for air? Do you hear that they're stopping breathing? Is there any mouth breathing at all? Are their lips apart? Is the mouth open? Do they move around a lot while they sleep? Are they sleeping in strange positions to keep their airway open? Are they waking up throughout the night? Are they bedwetting from the fear that they're going to choke themselves while asleep? Do they sweat and do they pant, like we saw with Austin? Are they grinding their teeth? Are they extending their neck? Are they waking up still tired and fatigued from the battle of the night? And so if we identify these patients, the standard of care right now that we're moving away from is an in-lab polysomnography. So this is a study where you take the young kids, we put them in a completely foreign environment away from their parents. You hook them up to airflow monitors, to a heart rate monitor, to an oxygen monitor, to a CO2 monitor, to thoracic and chest belts to see when their chest is rising and falling. And we're trying to study sleep apnea as if this is a scientific experiment. But the very fact that you're submitting these kids to a foreign environment and attaching all this, it's going to disrupt their sleep. And so you're not getting a very adequate reading unless you're dealing with something like moderate or severe sleep apnea. But a lot of these kids are presenting with either mild sleep apnea, where they're only stopping breathing 1 to 5 times an hour, or even something called upper airway resistance syndrome, which is characterized as multiple arousals. They're waking up about 10 times per hour, but not losing oxygen. We call that UARS. And so, okay, they've come out with some equipment that you can buy and you can take to the patient's home. So maybe they're sleeping at home and their mom can sleep on the couch next to them. And so, yes, there are home sleep tests, but again, you're only really looking for mild sleep apnea, moderate or severe sleep apnea where they're not breathing and they're losing oxygen. You're not going to pick up the arousals in this case because there's no way to know what kind of stage of sleep they're in, and there's no way to detect the changes. And so there's also things that only measure oxygen levels. But these things that only measure the oxygen levels are only going to pick up the most severe kids. And it's going to miss a lot of in between. And so out of Stanford, there's this new startup company. It's called NIT. And this is a video monitor sleep study. It's a camera that goes in the corner of the room. Kids don't see it. Nothing is on them. There's no probes whatsoever. And it's monitoring every movement they have throughout the night. And what they can do with this technology is they can see how many times per hour are you waking up. And not only that, but based on their position and the rise and fall of the chest, they can also detect if they slow their breathing and have a hypopnea, like in this case, like in the middle case, or if they completely stop breathing altogether, like the one in the bottom right. And it can break it down hour by hour. And you can see that, hey, it's when they're in their deepest stage of sleep that they're waking up the most. And yes, the average is low, but what's happening in those most critical stages of sleep? And so we have to get more sensitive. And so should you go for this study? Should you not? Everyone has an iPhone or has some kind of mobile app. It'd be very easy to download an app. It's called SnoreLab, and I'm sure there are other ones out there similar. And you just kind of record it. You record you're sleeping for a night. And it gives you a snore score. And so here's a snore score of one of our patients. She had a snore score of 18. So snoring is not the same throughout the night. You go through different stages of sleep and different positions. And we put her through myofunctional therapy. And myofunctional therapy substantially improved the snoring down to a score of 7. And in our practice, as we'll talk about on the last section, it's when the patient's beginning to respond to the therapy that you know you're on the right track and that the frenectomy can be helpful. And so in this case, we got him down from an 18 to a 7 just with therapy. And then we did the lingual frenectomy, the frenuloplasty, and we got her snoring down to a score of 1. And so the purpose of going through all this is to kind of show you that there's a spectrum of pediatric sleep disordered breathing. Usually starts with mouth breathing or noisy breathing. And this is usually the first sign that something may be wrong. They may just present to your offices with dry mouth, dental caries, or periodontal disease. They may just have a habitual mouth breathing, get sick all the time, allergies. And then these patients may start with the tongue and lip ties, and then it goes untreated, and then it can lead to tonsil growth from the open mouth breathing and the predisposition to allergies. And it can lead to an underdeveloped maxillofacial skeleton. And even then, you still don't have sleep apnea. So if you did a sleep study, mouth breathing would be normal. UARS may be normal in a lot of cases. And so this is the increased efforts to breathe, like we saw that kid. The breath is coming. He's not losing oxygen, but there's a problem. It's way too effortful. The sleep is way too restless. He's waking up hour after hour, minute after minute, and he's hyperactive during the day. Why? Because he's in fight or flight mode. He's overwhelmed with sympathetic tone to stay awake. And these patients might have kind of large-ish tonsils, not so bad, maybe a little bit high arch palate, maybe a little bit of myofascial dysfunction. And remember, this is a syndrome. And so what a syndrome means is it's not like a science that everyone's going to present with 1, 2, and 3. No, this is not how it works in clinical medicine. Some people present with a little bit bigger tonsils. Some people have a higher arch palate. Some people have a more restrictive tongue tie. And so we have to look at the picture overall. And finally, then you have sleep apnea. And sleep apnea is repeated episodes of partial or complete airway obstruction that lasts for about 10 seconds or 2 breaths in the pediatric population. And then these are the kids that have the problem and are treated by our mainstream medical community. Nightmares, bedwetting, anxiety, behavior issues, poor school performance, stunted physical growth. And so what we're trying to do is raise awareness and improve better diagnostic tests that is able to pick up the other forms of sleep disordered breathing. So once you have them diagnosed with either mouth breathing, noisy breathing, UARS, or obstructive sleep apnea, you can begin to treat them. And we grade the necessity and the severity of the treatment based on how severe their symptoms are. If they're mouth breathing or noisy breathing, you can take more easy interventions and you can do it over a longer period of time. If they have sleep apnea and their growth is being affected and their performance being affected, you want to be more rapid and maybe intervene with multiple interventions at the same time. Myofunctional therapy, ENT surgeries, orthodontic treatments, pretty closely together. If they're in the middle, they can have, you can kind of measure it out and see which intervention would do first. And in the second half of the lecture, I'll show some studies by Dr. Christian Mugano that shows just that. How do you treat it first? But let's just go through and talk about all the different kinds of treatment for pediatric sleep disorder breathing. And the first one that we're going to actually talk about is CPAP. And so CPAP is a breathing machine. And this breathing machine is not oxygen, it's just positive air pressure. So it's like you put your hand outside the car window and you feel that pressure, or you blow on your hand, you feel that pressure. It's not oxygen, it's just a pneumatic stent that physically opens up the airway. So you can do it for kids as well. And you can put a little pressure thing on the nose, and as the airway is closing up, like we saw in Austin, the CPAP machine is going to push open to open it up. And so this is what CPAP looks like. And so the first half, we're seeing the airway close up. And we're seeing it close up from the lateral side walls. And we see this kind of presentation of lateral side walls. It's most often an issue with the maxillofacial skeleton. And halfway through, we turn on the CPAP. And see what happens with the CPAP? It physically stunts the airway open. Physically pushes it open. But in the process of doing that, it can also force the air down into your stomach so that you're having upset stomach and aerophagia and a high pressure. And it's not the most comfortable. So a lot of times patients can't get into the deep sleep and they stay more light sleeps. So even though they're using this machine, they don't really feel all that refreshed. And so in 1995, there was a study at Journal of Pediatrics that showed that CPAP is safe and effective for use in pediatric OSA. But then as we learned and we studied these patients, we saw that the patients who used the CPAP were worse off than those who didn't. And this is because the pressure of the CPAP on the midface actually restricted the growth of the maxillofacial complex. And so what we want is for the face to grow forward. We want the face to grow forward because as the bones grow forward, the soft tissue comes forward, and that's how you're going to open up your airway. And so in my practice, CPAP is the last resort when it comes to pediatric sleep apnea. Because pediatric sleep apnea, they're not losing oxygen, so you don't have to force oxygen down their throat. You're trying to get them to deeper, more restful stage of sleep and set them up for long-term sleep and breathing success. In adults who are losing oxygen below 90, 80, and they're turning blue and they're at risk of cardiac issues, those patients you want to stabilize and then cure. And so the first treatment in my practice is not CPAP, but it's therapy. And when we talk about therapy, we talk about myofunctional therapy. And I was honored to participate in this study by first author Matt Camacho, in which we did a systematic review and meta-analysis of the literature showing that myofunctional therapy reduces the AHI by about 50% in adults and 62% in children, with improvements to daytime sleepiness and snoring, showing it to be effective in our practice. Our youngest patients in our office are 3, and our oldest patient is 79 years old that we successfully cured with myofunctional therapy. and it plays a very important role in preventing relapse. And so there's a lot of different kinds of and indications and clinical practice patterns for myofunctional therapy. But overall, if you just want to take at the basic goals, it's very simple. You want to get your lips together, you want to get your tongue up on the palate, and you want to encourage nasal breathing. And how you do that is going to be individualized to the patient in front of you, and it's going to be a problem-solving game. You're going to see what's keeping this individual from getting their lips together. Is it a lip tie, or is it behaviorally learned? Because a lot of times in my practice, I'll see brothers and I'll see siblings. One sibling is 5 years old, 6 years old, and the other is 3 years old. And the older sibling has a lip and tongue tie, and his lips are up like this, can't get their lips together, and the tongue is low, and they're a mouth breather. And the younger sibling, totally fine, mouth breathing, learning from the brother. So you have to work with the patient, and so one case needs myofunctional therapy, tongue lip tie release, the other needs behavioral retraining. And here's an article by my mentor, Dr. Christian Guilleminault, that is identifying that the goal is continuous nasal breathing as the ultimate treatment goal in pediatric sleep apnea, with research showing that myofascial reeducation plays an increasingly important role in pediatric sleep disorder breathing. They took 24 children with sleep apnea who were cured with either tonsillectomy, adenectomy, and/or orthodontia, and they referred them all for myofunctional therapy. 11 completed therapy, and 2 years later had no sleep apnea whatsoever. The ones who did not pursue therapy had a relapse of their sleep apnea. And there's a lot of evidence coming out, mainly opinion papers and reviews, showing that the ultimate goal is to secure exclusive nasal breathing to optimize craniofacial growth. Because the truth is that mouth breathing can actually change the shape of a child's face. And mouth breathing is really the smoke that can lead to the fire. We'll learn a little bit more from one of my other mentors, Dr. Bill Hang, who is here.
This is John Mew's pictures, and if you understand what goes on in this case, you understand more orthodontics than most orthodontists do. How can a gerbil change a face? This kid is a physician's son in England, and he was absolutely fine in the first picture over here. You can look at him, he looks great. His lips are together, and his face is in nice proportion. Over here, he's not looking so good. These are the same age. You can see his lower lip is flaccid, his chin is falling back, and his cheek is getting very flat. He bought a gerbil, kept it in his room, and was allergic to it. Went from being a total nose breather with his lips together to hanging his mouth open. And that's what happens with our children all the time. The same thing has been shown by Eagle Harvold, where he took monkeys, perfectly normal monkeys, and plugged their noses up, and their faces got long, their maxillas got narrow, their tongue posture was low, and they developed malocclusions like humans have.
And I thank Dr. Hang for being one of my teachers. And so what we learn is that the tongue serves as an important scaffold for the development of the maxillary arch. And when you have a high tongue posture up against the palate, the teeth will come in and develop a nice, broad, U-shaped arch. But if you have mouth breathing issues for any reason, or you have a tongue tie issue that's keeping the tongue low, the tongue cannot function adequately as a scaffold, and you get the dental crowding issues and a V-shaped arch. And so these kind of issues have been well known in the community and lectures, but there's no evidence for it. And that's why it's so exciting for me and my colleagues to come attend these lectures, because we see these slides and we realize there's no evidence for it. And so what I'll show you in the next lecture is how we're piecing together these very easy research projects to reaffirm and reestablish things that are commonly held beliefs in the community. And so when we're talking about high or low tongue posture, let's take a look at my fiancée to demonstrate for us. High tongue posture, we mean up against the roof of the mouth. Low tongue posture, we mean down. And you can ask patients, you can just kind of put your lips together and kind of ask yourself, is my tongue down at the lower teeth, in between, or firmly up against my palate? And is it the front of the tongue that's up, or is it the whole back of the tongue? And that's the essential premise of what we'll be talking about over the course of the weekend. And any procedures that are done with that goal in mind, to restore the tongue position up to the roof of the mouth. And as we're learning about this, we have to keep in mind that lip and tongue tie is only one or two causes of open mouth posture. There are many, many, many different causes for open mouth posture. And open mouth posture can cause many different presentations. And these cycles feed into each other. Okay? Lip and tongue ties can lead to craniofacial dystrophy, which leads to bottle feeding and soft diet, which leads to further other issues, back and forth. And so I want to be modest in saying that, yes, lip and tongue ties do contribute to this, but there's a host of other issues. And so the best therapists are those who are going to take a history and they're going to tease out what issues are affecting the patient in front of me and use any surgical modalities very judiciously, because you want to have a very, very high success rate when you're picking your candidate. Because we all depend on each other to advance this field, and we do not want to do procedures when we're not sure if this is the right thing to do or not. We want to be sure this child is mouth breathing because they have a lip tie or they have a tongue tie. They don't have anything else going on. We've checked the birth trauma, the cranial stays, the posture, the feeding issues. It's probably this. Let's see. And so in my practice, I'm an ENT. And so really one of the first things I do to test for mouth breathing is make sure they can breathe through their nose. And here are two methods to do that.
So a lot of times if you ask a person if they're breathing through their mouth or their nose, they'll instinctively tell you that they breathe through their nose. But one way to check to see if they are breathing through their nose is if you take a mirror and just hold it under their nostrils, and you can see the fog develop on the mirror. This way you can also see if one side is more blocked than the other. Okay, one way to check to make sure that someone can breathe through their nose is to take a piece of paper tape, and we're going to tape the mouth closed, so that will force them to breathe through their nose. So I'm going to take a piece of paper tape, and I'm taping the sides of the tape down, just so it will be easier to remove in case somebody can't breathe through their nose. With the Rosenthal test, this actually tests to see whether mouth breathing is a habit or whether they cannot physically breathe through their nose. So you're supposed to put the tape on their mouth, which closes off the oral cavity. This way they are forced to breathe through their nose. And we want to test whether they have nasal patency, whether breathing through their nose is something that they can do. And this way we can rule out if there's any other issues that need to be addressed by an ENT.
Okay, and so really the first thing is to establish nasal patency. And if they can't breathe through their nose, we want to treat it with saline rinses or allergy medications. And then once we've taken care of the nose, then you can move on to address other myofunctional issues, the lips and the tongue. And sometimes you have to consider surgery. And when we talk about surgery for pediatric sleep and breathing, really the main evidence and the main standard of care is, when we talk about surgery, we're talking about tonsil and adenoid surgery. And so what happens is that the tonsils and adenoids can get enlarged for a variety of reasons, among them mouth breathing. And they get enlarged because you get dryness over the tonsils, you get bacteria that gets trapped underneath, you get inflammation, and once you reach a point of no return, the tonsils get so enlarged that they're blocking up the throat, and they need to be removed. And so this is what it looks like when the tonsils are blocking the airway. Here's a child that I took to the OR. It's about blocking about 75% of the airway here. Take out the tonsils and open it up so they can breathe. But it's not only about the tonsils. Tonsils is one thing, maybe about 85%, but 15% of the time, they have a tongue posture issue. And even though there's no tonsils there, the airway is wide open, the tongue is held down. And when you have low tongue posture, what happens is the tongue can narrow the airway, contribute to snoring, or it can even block the airway, contributing to apnea. And so sometimes large tonsils and adenoids cause the tongue to go down, and sometimes the tongue being down causes the large tonsils and adenoids and the sleep issues. And let's see an example of those things. Here's a 2-year-old child with enlarged adenoids. Let me see if I get this. Okay, so the adenoids sit right here, you can see here. And there's a blockage in the passage of air through the nose and down the throat. And here's the tongue here. And what we see is a black line between the tongue and the palate. Let me take it back and forth again. There's this little black line here. You guys see that? What that means is the tongue is being forced down because the child cannot breathe through the nose, and there is no way to breathe through the mouth if the tongue is up. The tongue has to come down. So here we're seeing that this kid had allergies, couldn't breathe through the nose, is pushing the tongue down a little bit. When they're 2, when they're 3, it'll go lower, 4, 5, and now, yes, you had the allergy issue, you had the adenoids, but now you have a myofunctional issue as well. So when they're 3, 4, or 5, you'll take the tonsils and adenoids out, but as I'll show in the next lecture, only a fraction of those kids are still going to be doing well. The rest will still be mouth breathers, because for 3 years of life, for 2 years of life they were nose breathers, 3 years they were mouth breathers. You have to re-educate them. So that's one reason you can get low tongue posture. The other reason you can get low tongue posture is the tongue is physically held down. And so what we see on this CT scan is the tongue is right here. And there's this gap here, and you see the high arch palate. And it's a very different presentation. So the other child with the adenoids needs to get their adenoids removed, allergies, teach them to get their tongue up. This child, okay, you can see the tongue here. This is the tongue here. It's physically held down. It's very different. You look underneath their tongue, there's the tongue tie right there. There's the dimple of the posterior tongue tie attachment, pulling up on the floor of mouth. And we'll describe to you in the lectures that come how we're changing our classification system to identify these kinds of tongue tie. Because this tongue tie is not going to cause speech or swallowing issues. This tongue tie is going to cause sleep and breathing issues. And so that's what brings us into tongue tie surgery. And so what we want to demonstrate is that, yes, sleep and tongue tie can affect speech and swallow, but it can also affect sleep and breathing. Maybe not all the time, but there are cases in which children present with tongue tie issues that can be ameliorated with surgical intervention.
My name is Danica, and this is Madeline.
Hi, Madeline. And you guys are here for us to check out your tongue.
Yes, her tongue, because she had a problem with her tongue. Well, mainly is the feeding issues and waking issues as well. She's been on a 30-pound weight. We kind of want her to gain more weight, and then, she's also here for tongue-tied issues. And a little bit of background on Madeline. She's kind of ever since she didn't have a problem with breastfeeding. She was breastfed for 10 months, but she had a problem with more of a solid food. She preferred more of a softer food like fish. Whenever she tries to choose any hard food, then she would just basically would chew it for like 30 seconds and would try to spit it out. So it was never a concern for us because, you know, we just thought she was just growing. But now that we saw a professional doctor and special doctor, then she is now at I believe at diagnosed with this class 4, grade 4 tongue tie. Hi.
All right. Well, let's take a look, Madeline. Open up wide for us.
Can you open up, Maddie? Can you open up?
Good. And stick out your tongue.
Can you stick out your tongue, please? There you go.
Okay. So she's having trouble chewing because she's having trouble moving the food from side to side. She's having trouble breathing and also having some speech issues. Is that right?
Yes, and she also she normally snores every night when she sleeps, and she can only sleep on her left side. Can never sleep on a lay flat. The other issues that we were having is that she would wake up 3 to 4 times every night, just to wake up a big gulp of water, and that was one of the things that we were concerned of. Hopefully with this surgery can help resolve that with the sleeping problem, and also the asthma and cold that she's been having as the,
Yeah, all right, thank you so much.
Yeah, you're welcome.
So this is a case I did in a general. I'm now doing 4.5 and above awake, and we'll talk about the way we do the surgery in the last segment, different ways to do it.
So on the first day, we've had a great improvement. Actually, before the surgery, Maddie was doing a lot of myofunctional therapy as well. But before this surgery, she actually was having a hard time chewing her food. That was one of the problems. That's why we came here as well to Dr. Zaki, because she would pocket her food all the time. I would take her at least 1 to 2 minutes for her to swallow each bite. But I realized on the first day of the surgery, she ate like rice and like grilled fish. She ate everything like so fast, as if she had no problems at all. And that was like really fascinating for us to see, because we haven't seen that for a long time. Actually, we've never seen her do that. A lot of other problems that she encountered before the surgery was that she would always snore when she sleeps, or she would have her mouth open. And sometimes you kind of hear a little bit wheezing, because she would always get chronic cold or cough. You know, I noticed the 4th day last night, I noticed that she actually slept with her mouth closed, which is really fascinating to me. And I would, you know, turn her to the middle side, and normally she would turn right away to the left side or the right side. She actually kept on the middle side, on her back side. So that was really fascinating to see the improvements, like after just the 3rd day after the surgery. So we're really pleased with the service that Dr. Zaki had provided us, and also, Ginny was doing her therapist as well. So really happy with the outcome.
Yeah.
Just the 4th day and the 5th day. She actually.
So yes, she still has the lollipop, and so we're gonna wean that off. It's a sugar-free, just to get him to open up. And so it's a process. And so tomorrow, at the end, I'll show you the 2-month. And so you just want to take it step by step, and we want to make sure that we're not traumatizing our children. And so if I can use a lollipop to take a look in their tongue or get their tongue up, we will, because it's a process. But yes, ultimately, you don't want to do that. So here she is, pre-op. Okay, noisy breathing. Her sleep study would come out normal, which is why it's so hard to do these studies. Okay, and post-op, and she's sleeping on her side. Post-op, let's turn the volume up. Maybe you're hearing the mom's breathing louder than hers. Okay, this is the goal of any treatment you're going to do. How we get them here, we have to work together in teams to figure out what's the most important intervention, but this is the goal: quiet nasal breathing. How did I get introduced to this? It's when I was a fellow at Stanford, I was really interested in learning everything I could learn. And so here's Dr. Christian Guilleminault, and this has become his obsession. So much so that before I went in, some of the previous people went through it, said, watch out for him. He's going to pull you in and say it's all about tongue ties, but you got to keep it kind of okay. But I said, let me start working on the research. And so I was fortunate to work on this research project with him. And it was my first foray into tongue tie and short lingual frenulum studies. And so what they did is they took 150 pediatric patients with sleep issues, and they categorized them in 2 groups: those with the short lingual frenulum and those with the normal lingual frenulum. And for this, they actually used Dr. Mark Hassan's protocol, Mark Hassan's protocol, to identify who's short, who's normal. And they looked at other things as well. They looked at their tonsil size. And so tonsil size is graded 1 through 4 based on how much of the throat is being obstructed. So you can see the number 1, the airway's wide open. You can barely see the tonsils. 2, it occupies less than 50%. 3, it occupies 75%. And 4, more than 75% of the airway. Also by the tongue position, the Mallampati tongue position. So class 1 is a wide open tongue position, whereas class 4, you're obstructed. Sometimes you can be obstructed because of a tongue tie issue, sometimes because you have a narrow maxillary arch, and sometimes because you have a small mandible. They also looked at high arch palate. But what this study was groundbreaking for is that it showed that there are different phenotypes of sleep apnea. What that means is that not all kids with sleep apnea are going to present the same. Some kids present with large tonsils. You can see a score of 3 on the tonsils, and an okay Mallampati of about 2.86, and not really a high arch palate, maybe sometimes. And they have an AHI of 11.4. And there's another group of kids with a short lingual frenulum where the tonsil really isn't the issue. But if you look, they have a poor Mallampati score. They have a lot of dental crowding in there. Their tongue really can't fit in their mouth. They have a high arch palate. And these kids tend to be a little bit more severe. Some tongue tie is obvious, and some tongue tie is not so obvious. And so this is the tongue tie right here. Yes, the front of the tongue is mobile, but what about the back of the tongue? And in this tongue tie, yes, you're able to get at the tip of the tongue, but look at the compensation you're doing on the floor of mouth. You have to pull the floor of mouth up in order to get your tongue up. You're going to be forced into a low position. Yes, you can do it during speech and swallow, but the chronic strain may cause other issues as problems later on in life. And so the current standard of care is to use the Kotlow-free tongue measurement. This has been validated in ages 18 months to 14 years. And it says that complete ankyloglossia is less than 3 millimeters. Severe, it's when the tongue tip to the frenum attachment point is 3 to 7 millimeters. Moderate, 8 to 11. Mild, 12 to 16. And normal if you're more than 16. So that if you have a case like this, yes, this is severe ankyloglossia. But what about 15 to 17? This would be characterized as mild to normal to current standards, which is why before we can even do the studies to show that these things work, we have to change and revalidate the tools we're using to measure our outcomes. And that's where we are in the stages of research. We're coming up with new and better tools to grade what is a tongue tie and what is not. And it's not only about length, it's about tongue mobility, because it's about how far up you can get the tongue. And I'll spend a little bit more time talking about this. But basically what we're doing now is based on the tongue range of motion ratio. We have the patient open up their mouth all the way. This is the maximal interincisal opening. And then we have them put their tongue right behind the incisive papilla, and we get a ratio. And again, I'll go through again on this on the last day. It will be more clinical. And so you get a ratio. And so if they're able to lift up their tongue more than 80%, that puts them in the top 10th percentile of tongue mobility, and it's considered a grade 1. If they're 50 to 80%, it's grade 2, which is average, and most people have this. If they're less than grade 3, it's below average, and if it's less than grade 4, it's bottom 10th percentile. And so what we're finding is that we want the tongue to be up, not only the front of the tongue, but the back of the tongue as well, because when the back of the tongue is down, it can block the airway. We asked the question whether restricted tongue mobility can affect the development of the maxillary arch, and here's a study done by Audrey Yoon showing just that. Now that we're able to divide and know about grade 3 tongue ties, not only grade 4, but also the grade 3s, we can show that, yes, there's a clear divide. It's not only the grade 4s that are relevant, but the grade 3s as well, such that if you have a grade 3 tongue tie, you're more likely to have a narrow V-shaped arch. This study would not be possible without the functional scale, because the grade 3s would have been put in the normal category, and the grade 3s would have been the same as the grade 4s, and there would be no difference. But now that we're able to categorize the grade 3s with the grade 4s, we're able to see a clear divide. And it also been shown to have a narrow south palate. And so grade 3 and grade 4 tongue tie is associated with a narrow V-shaped maxillary arch. But at the same time, it only accounts for 7.6% of the variance. What that means is that if you have a tongue tie, you have a 7 to 10% increased risk of a narrow arch. It's not 100%. Doesn't mean if you have a tongue tie, you're going to get a narrow arch, because it's multifactorial. And when you have the narrow arch, that's when you get into dental treatment for sleep apnea. There are different kind of expanders that you can use, functional appliances, expander appliances. And really, the purpose of this lecture was to kind of introduce to you where tongue tie fits into the overall picture. This is a complex issue. There are multiple pieces to the puzzle. We've provided a little bit of an overview here, The next lecture will focus on a review of literature, going more into depth, and finally we'll show you really how we do it. I want to thank you for joining me on this journey.